Good afternoon, everybody. My name is Soshenda Stevens. I am the program manager for the Alzheimer's Research Center. And on behalf of our center, I'd like to welcome you to our second annual Lewy Body Dementia Community Conference. Whether you're joining us here in the Kinney Auditorium or tuning in virtually from home, we're so glad you're here with us today. Lewy body dementia is one of the most complex and misunderstood forms of dementia. It can be incredibly challenging, not only for those living with it, but also for families, caregivers, and clinicians. That's why today is so important. This conference is designed to inform, support, and empower you. Over the next hour, you'll hear from leading experts in the field, Dr. Graff-Radford, Dr. Dickson, and Dr. Tannis Ferman, who will share the latest insights on treatments, pathology, neuropsychology, and the current research that is happening now. For persons living with Lewy and their caregivers who are joining us in person, you will have the opportunity to attend the fellowship and support session, which will be led by our certified support group facilitators, Christine Trent and Candice Christensen. We hope that by the end of today, you'll walk away not only with new knowledge, but also with a greater sense of connection and hope. Whether you are here to better understand the disease, stay updated on new research, or find support from others who share your experience, you're in the right place. Thank you for being a part of our community. Today, you will hear from each of our presenters, followed by a question and answer panel. And on your table, you will see some index cards. So should you have any questions throughout the presentations, please write them down and then hold up your cards, and a member of our team wearing blue will stop by and grab the cards. And then at the end of all of the presentations, we will answer your questions. For those of you joining us on Zoom, please send your questions through the chat or ask a question feature. And when you checked in today, you were also given a raffle ticket. So after the panel discussion, we will be raffling off some gift baskets and other fun prizes, so please keep your tickets handy. And lastly, please help yourselves to some coffee, tea, and snacks located to the side of the room. Okay, so now let's get started. I'd like to introduce our first presenter of the day, Dr. Graff-Radford. So Dr. Graff-Radford is a board-certified behavioral neurologist with over 40 years of experience in the field. He is the medical director of the Memory Disorder Clinic, co-director of the Alzheimer's Disease Research Center, and the principal investigator of the Lewy Body Dementia Association Research Center of Excellence at Mayo Clinic in Florida. Dr. Graff-Radford is also a member of the State of Florida Advisory Board on Alzheimer's disease. Dr. Graff-Radford's research focuses on the genetics of degenerative brain disease, biomarkers in dementia, Lewy body dementia, frontal temporal dementia, and normal pressure hydrocephalus. He has published over 775 peer-reviewed papers and is the David Eisenberg Professor at Mayo Clinic. He is also the 2023 Mayo Distinguished Investigator. So please welcome Dr. Graff-Radford.
This one? Yeah, thanks. Well, welcome everybody. Thank you so much for joining us and spending some time with us. We've got quite an interesting program. I'm looking forward to it myself. My two incredible colleagues, Dr. Dickson and Tannis Ferman, are, you may not know this, but very famous in the field of Lewy body disease, amongst other things. Dr. Dickson is the 23rd, or about 26th, I think, most published scientist in America. He didn't know that, but he is. And Dr. Tannis Ferman and I have worked on Lewy body disease for more years than we'd like to tell you. Anyhow, Lewy body disease has evolved over the time that I've been working. In fact, we didn't even recognize it as a disease for a long time. We missed it all. We thought people who had what's called Capgras syndrome may have some psychiatric problems where they misrecognized their own family members, like their spouse, as somebody else. That's Capgras syndrome. That's part of Lewy Body Disease. And we didn't even realize that in the beginning. Also, visual hallucinations we thought were part of Alzheimer's, but they weren't, in the beginning anyhow. So we've learned a lot, and as time has gone by, and we now have a lot more good information, and we're going to share some of the latest of that today. Let's see how this works. So I'm going to discuss the key features of Lewy body and then the new biomarkers, and then I'm going to discuss some potential treatments for it, the standard treatment, but there are now 3 clinical studies that have finished phase 2, and we have some good results in some of them, so I'm sure you'll be interested in hearing all about that. So I don't have anything to declare.
How long has this problem gone on now?
The best I can recollect, last November, a year ago, he was very well. He could take care of himself and everything. And then in December, everything flew out of his head. He couldn't remember anything. And he was starting to have bad hallucinations. He would see people out in the backyard all dressed up in military outfits. He would see somebody hanging on the fan in the bedroom and the fan was going. He was going around with a flashlight looking under tables and chairs and the closets. He was sure that there were people all over the house. And then, did you want to know about the episode with the police?
Please.
It was one evening about 1 o'clock in the morning. I heard somebody calling to me, and when I went out into the den, there were 2 policemen there. He had dialed 911. He had said that there was somebody trying to kill us, and he went out the front door, and while he was doing it, he stopped in the kitchen and grabbed a knife. And then he hid out in the bushes in the backyard, and that's where the police found him. So really, since starting January, he has been worse than ever.
Times?
But like I say, he doesn't know me a lot of the times. He doesn't.
Tell us about that.
He calls me, my maiden name was Finn. He'll say to me, "You're Virginia Ann Finn, but where is my wife Ginny?" And he can't get it together that I'm one and the same person. Then he asks me how I'm related, because he's not sure what I'm doing there.
How long are you guys married now?
49 years, October, this month.
Congratulations. May I ask then also about sleeping? Tell me about his sleeping.
He sleeps constantly. Other than when he's eating, he doesn't watch television or anything, so he just goes to sleep. And he says, "I'm very tired." But he talks and carries on all night long in his sleep.
Does he move as well when he sleeps?
He moves his legs, but mainly he's talking or screaming out or something like that.
Does he seem to act out his dreams?
Yes, because when he wakes up, he'll tell me about the people that were all in the house, and he'll close the bedroom door, don't let them in, and things like that.
Mm-hmm. Now, is he bad all the time, or does sometimes he get better or worse?
Well, that's the thing that's kind of hard. One day he'll seem absolutely fine, and I'll get my hopes up and say, "Oh, maybe this is reversing itself or something." Mm-hmm. And then the next day he's back where he started from. No.
What about his handwriting? Has that changed?
That has deteriorated.
Is his handwriting bigger, smaller, same size?
I would say smaller.
Smaller.
I don't know if that makes any sense.
What about doing things like buttons and laces?
No, but then he has arthritis, but I have to Definitely not. He has to sit and think. After I say anything to him, he'll just sit and think. And then he might come out with the most outlandish comment that had nothing to do with...
Quite an amazing story, isn't it? I think if you think of this case, you actually understand all the symptoms of Lewy body disease. Did you recognize visual hallucinations, that he sees things that aren't there? Did you recognize Capgras syndrome? Didn't recognize his wife. Did you recognize acting out his dreams or REM behavior disorder? Did you recognize what's called fluctuations? Some days I get my hopes up and then he crashes again. Did you recognize that he has Parkinsonism, that his handwriting's smaller, and that he's not moving as well? You got it. Now that's the tutorial. Case conference over. It's his wife was an extraordinary good historian, and we didn't know a lot about Lewy body. This was about 2001, sort of almost 25 years ago, and we didn't know about some of the treatments, and I'm going to show you some of that in a little while. Anyhow, so I'm going to start with what's called the consensus criteria. Ian McKeith is a very famous psychiatrist from Newcastle, and he is the leading person, I guess, on Lewy body disease clinically. He's the one who recognized it and brought it to our attention so that we now also see it. We used to look but not see, but now we actually see because of him. And then we're going to talk about clinical features and the biomarker and the treatment. So let's start with consensus criteria. This is Ian's, the most recent of the papers. You can see Ian's the lead author on this paper. And you don't have to worry about this. I'm going to break this out a little bit, but this is the table that's in that paper. And I'm going to show you that. So the clinical core features, here they are. Fluctuating cognition with pronounced variations in attention and alertness. Sometimes he gets my hopes up that he's going to improve. Recurrent visual hallucinations. He sees things hanging on, those are the same things. REM behavior disorder. He acts out his dreams. He was also sleepy during the day. That's another big feature. That's also part of the sleeping problem. And Parkinsonism. Small movements and so on. So you guys knew this already, right? And then fluctuations. These are episodic confusional states resembling delirium, transient periods of reduced loss of consciousness. People are admitted like this and they thought to have a stroke. Or they have what they think is sundowning. Or they call it confusional state. Or they think it's toxic metabolic, that they've got diabetic coma or renal impairment or heart failure, respiratory problems. That's what it looks like. It's hard. And then hallucinations, they're often well-formed. They occur in 32 to 85% of autopsy-confirmed cases. And if they have Alzheimer's with concomitant Lewy body, it occurs in that number, you can see. And when visual hallucination developed within the first 5 years of dementia, the odds are 4 to 5 times later that they're going to have Lewy body disease. What I mean is, if hallucinations occur in the first few years of dementia, that's Lewy body. If they occur 5 years into the disease, that could be Alzheimer's. And Tannis and one of my fellows and I published that a few years ago. So rapid eye movement. So when you are sleeping and dreaming and your eyes are moving around, fortunately you're paralyzed. You can't move. It saves you from beating up your partner. But in Lewy body, because of the pathology, that paralysis goes away. So you move, you act out your dreams. That's what rapid eye movement behavior disorder, REM behavior disorder is. Okay, so that's what it is. And so we had 172 people who had documented sleep studies showing they had REM behavior disorder, and they died. And Dr. Dickson did an autopsy on every one of them. And we found 97 of those had Lewy body, 32 had Parkinson's, 19 had called multiple system atrophy. All of those have synuclein protein deposited in the brain. So synuclein has a predilection to be deposited in a specific place that causes this problem. So if you have REM behavior disorder, very likely it's a synucleinopathy. It's one of these three. Occasionally it can be a mistake, it can be Alzheimer's disease. But look at it, 9 out of 172, that's not many. So when we see REM behavior disorder, we're very much alerted that this is a synucleinopathy. And the pathological diagnoses, there are all sorts of things that can be combined. So what's the question? The core question is, do they act out their dreams? And the sensitivity, if they say yes, it'll catch 98% of Lewy body cases. If they say, but it isn't specific, some people say that they do it, but it's due to something else. And the commonest cause that looks like Lewy body is taking antidepressants. It looks like acting out the dreams, but some of the antidepressants, the SSRI inhibitors, cause REM behavior disorder. So we have to be cautious of that. And also patients aren't always 100% accurate in history. You're not surprised to find that. And then another core feature is Parkinsonism, bradykinesia, rest tremor, and rigidity. And it's common in the community. 15% of people 65 to 74 have a little bit of Parkinsonism. You probably know that when you look around, people walking around. And at 75 to 84, 52% have some Parkinsonism. Fewer than half of DLB cases have Parkinsonism at the presentation. So very often clinicians say, this patient doesn't have Parkinsonism, can't be Lewy body. But 50% at the beginning don't have it. They eventually develop it, mostly. But you don't have to have Parkinson's at the beginning. So that's important to understand. Here are supportive clinical features from that table that I showed you. Severe sensitivity to antipsychotic agents. This is really important. So when people have delusions and hallucinations, they are psychotic. And they are taken to the ER with that, and they take out the big syringe with vitamin H called haloperidol, and they inject them because that's the standard treatment for schizophrenia, and you paralyze the people for a month. They are so sensitive to this. So Lewy body patients we have cards we give them to say, tell your doctor not to give you these medicines. And Haldol and some of those other antipsychotic medicines can cause Parkinsonism, which lasts a long time and really is disabling, can even be life-threatening. And then they often have repeated falls, and they have syncope because they have dropping blood pressures, autonomic dysfunction. So orthostatic hypertension, that means when you lie down, you take your blood pressure and you stand up, and your blood pressure drops more than 20 points, that's orthostatic hypertension. And it's due to the synuclein being in the peripheral nerves, in the sympathetic nerves, that they don't work so well. So you faint or pass out. And they also may have hyposmia. They may lose sense of smell. That's very common. And they also may have anxiety and depression. I think anxiety more than depression actually is what worries me, what I see more in Lewy body. I don't know, Tannis may have her own opinion on that. All right, neuroleptic sensitivity. I told you about the Haldol story. And then repeated falls. We've talked about that in the autonomic dysfunction. Very much what I've just told you. And then indicative biomarkers. What biomarkers can you use to support the diagnosis strongly? So there's reduced dopamine transporter uptake in basal ganglia, and we do a SPECT scan or a DAT scan, and we see that there's hypometabolism in the basal ganglia. I'll show you a picture of that, what that means. Or another one is you may look at the heart and look at the dopamine markers in the heart, or you may do a sleep study and see that they prove that they have REM behavior disorder. And so let me show you what that looks like. Okay, so you can see on the left is the Alzheimer's, on the right is normal, and it's like a comma in the basal ganglia. But the DLB have like a period in the middle, right? So they've lost the dopamine transporter, and you can see that on what's called a DAT scan, or a PET scan. So that's what that looks like. Here is the heart one. On the left is Alzheimer's, on the right is normal control, but in the middle, no dopamine in the heart. And they're beginning to do this more commonly now, so that's important. And here is the REM behavior disorder. Look at the green arrows. The person has REM, look at their EOG, that's their eye movements. You see how their eyes are going wild, but their muscles in their arms and legs are completely silent. They don't move because they're paralyzed, right? Now look at their eyes moving in B, and what's happening is their muscles are moving. And so they have, they have the ability to act out their dreams. They're not paralyzed when they're dreaming. So REM behavior disorder. All right, and sometimes EEGs may be abnormal, and we're going to show you what we see on the CT scan and the PET scan. The PET scan, this is deoxyglucose PET scan, and it shows metabolism of glucose in an anatomical distribution. And characteristically, you have decreased, you see where the blue arrows in the middle are, decreased red or metabolism of glucose in the occipital lobe. That's what Lewy body has. And then in the middle one where the yellow arrow is, that's called the island sign, because there is metabolism in that area, because in Alzheimer's disease that area has pathology or tau pathology, and you don't have that island there. So those are the two characteristics of a PET scan that is of Lewy body disease. And now we're going to look at the hippocampus. These are coronal sections of the brain, slicing the face, moving backwards. The red boxes are looking at the hippocampus. And the hippocampus is the part of the brain that makes memory. On your right side, the NC one, that's a normal hippocampus. That one is normal size, probably makes good memories. On the left-hand side, the AD or Alzheimer's one, can you see the hippocampus has shrunk and they're like holes in the brain? And that's why Alzheimer patients have memory problems. Look at the middle one. The Lewy body is a little bit in between, but it isn't as bad as the Alzheimer's and not as good as the normal control.
Since we last saw Mr. Battaglia.
Sorry, I'm going to go back. So, several months later, we're going to see Mr. Battaglia, how he's doing. He gets admitted to the hospital. And I want you to raise your hands and say he's much, much better if you believe that. No? Nobody says that? You guys, no faith. He's worse. He's worse. So many people think. There's a few nods. He's the same. All right, let's see what we find.
Since we last saw Mr. Battaglia, there have been some new developments. He was admitted to hospital. Can you tell us about the hospital, when he was admitted, what happened, and when discharged?
He was admitted December the 13th, 98, with pneumonia, congestive heart failure, a problem with his diabetes, and an infection in the blood. Prior to that, he was in the same state as he was when we were last here. I didn't notice any changes in the hospital, but then he was sleeping a lot with all the medicines. But when he came home about the first week, I noticed he was completely different. He was alert.
The first week is when?
January 15th he came home. He was alert. He talked. We could carry on a conversation, which we haven't done in about a year. And he would get up and walk around. He slept well. And he was just a completely different person. Even the nurses from Baptist came over every week. They came twice a week.
And how many nurses confirmed?
I have four different nurses.
And they all agree with your observation?
Because one of them told me the other day, she spoke to another nurse and she said, "You didn't tell me that Mr. Battaglia was so well." She said, "I've been going a year there." And this is the first time I've been able to carry on a conversation with him. He'd just sit with his head hanging and not say anything to me.
All right. Mr. Battaglia, from your perspective, have you noticed a change as well?
I noticed my head's a little clearer. I can hold a conversation with other people. Before I was always fearful that I say the wrong thing or
have you found that your memory's any better?
somewhat.
Now, tell me about your hallucinations in the past compared to now.
I think what dwelled on my memory is these clownish, ghoulish figures that you see all around town. The witches.
Are you seeing them now, or has that gone away?
That's gone.
Okay, so
I had pictures of them looking down from the eaves of the room.
Mm-hmm. And you agree, Mrs. Battaglia, that the hallucinations are better?
Yes. If he has one a day, that's about it, and maybe not even that.
So a miracle, right? It was a miracle for me because I didn't know that you could get better. But we gave him donepezil or Aricept. That's what did it. And now we know that it happens quite often. We're very lucky that we have something that is helpful. Dr. Dickson will show you that the basal ganglia, not the basal forebrain, where the nerves that give off the acetylcholine, which is a neurotransmitter. Neurotransmitter is a chemical that helps nerves talk to each other. And the basal forebrain, all the cells that make acetylcholine are over there, and they go to the hippocampus and they juice up the hippocampus to help us remember things. And in this disease, this disease wipes out the basal forebrain, so you don't have acetylcholine. And what does donepezil do? It increases acetylcholine. So it's really quite remarkable that this actually works. All right, so we're going to have a brief discussion on biomarkers. This is one of the latest and greatest biomarkers. There are two really quite interesting biomarkers that have come about, and they do biopsies of the skin at the back of the neck, on the arm, and in the leg, and then we send it to a central place, and they're publishing, but we don't really believe this yet, that for synucleinopathies, those are those three diseases, Parkinson's, multiple system atrophy, and dementia with Lewy body disease, that 213 were positive and 10% were negative. 95% accuracy or a positive predictive value, so that you can see, when you do those biopsies, you can see the synuclein in the pathology. So far, we've had quite a few cases where we've done a biopsy and it's been positive, and the patient doesn't have Lewy body to our mind. Maybe they'll develop it one day, but so we're not sure about this. This is in a study, so it doesn't really prove anything from a clinical point of view, but it is interesting that it's becoming of note. And here's another one, the in vivo diagnosis of synucleinopathy, and again showing that it's actually very accurate. Skin biopsy sensitivity 90%, and then in the spinal fluid at the same time it's 78% sensitivity. You can see the specificity. So they're saying the skin biopsy is really outstanding. However, this is recently, just a few months ago, Doug Glasgow, who's at UC San Diego, published the clinical experience, and 72% of participants with clinically diagnosed with Lewy body had 137 out of 191 had a positive skin alpha-synuclein in the spinal fluid. So we still have to work out exactly the sensitivity and specificity, but you can see it really is interesting that maybe we're going to have a good diagnostic test. What we'll do is, if we're not sure, we'll do a skin biopsy and send it off to Dr. Dickson to look at it carefully for us, or send it to the lab, and they'll give us this. Also, this alpha-synuclein in the spinal fluid seems very promising as well. All right, one or two words on treatment. I want you guys who are interested in Lewy body to write down Diamond Lewy. This is, I think, one of the best sources of information, and it's from Newcastle, and it's free, and it's excellent. This is looking at each of the areas: cognitive, non-pharmacological approaches, and pharmacological use cholinesterase inhibitor, second-line memantine. That's how you treat it. Psychiatric, again, cholinesterase inhibitors. Did you see the hallucinations improve with our patient? Excellent. And be cautious on antipsychotics. Remember, I told you about that, even the newer ones. And they don't find any evidence that antidepressants are useful, which is interesting. For insomnia, they recommend melatonin. They don't like the Z drugs very much. Zolpidem may have a role, but you have to be very cautious with them. The REM behavior disorder, again, you should try melatonin, but clonazepam you can use, but it has side effects and people fall down on clonazepam. And then we treat the problems with Parkinson's with levodopa. And orthostatic hypertension, there we use all sorts of things, but including fludrocortisone and midodrine. And you can see some of the other things like saliva drooling, you can use Botox. So here are some of the important things in a nutshell, which you can download from Diamond Lewy. Very good information. Here are the 3 phase 2 clinical trials that these are actually unpublished, but Dr. Galvin has provided this for us. He said he'd give us what's going on. This drug called CT1812, which has also been tried out for Alzheimer's disease, we're using that, and it showed a positive signal in the few people that were the 130 patients. Can you see the, I don't know if you can see the positive signal that they found. The second one, it was a negative study. It failed to demonstrate benefit, but what they did demonstrate is the drug they were giving wasn't being absorbed. They then got a new formulation in the open label, and they gave the new formulation in the open label, and people improved. So they're going to do it again. But it might turn out to be good. And then the third drug also had a positive signal, but notice there are just 43 patients in that particular one. So there's something in the wings that might turn out to be useful for us, in addition to cholinesterase inhibitors, the donepezils, so just to tell you. So I'm going to stop there and pass it to my colleague. Who's next? You can do this. Thank you very much.
Thank you. And as a reminder, if you have any questions during Dr. Graff-Radford's presentations, please put it on the note card, and a member of our team will be stopping by to pick it up later for the question and answer panel. Alrighty, so our next presenter is Dr. Dennis Dickson. Dr. Dickson is the director of the Brain Bank for Neurodegenerative Disorders at Mayo Clinic in Jacksonville. The Brain Bank houses over 10,000 specimens, including more than 2,200 cases of Alzheimer's disease, more than 1,000 cases with Lewy-related pathology, and more than 1,000 cases of 4R tauopathy, mostly PSP. Dr. Dickson and his collaborators have been at the forefront of research on neurology and neuropathology, as well as the genetics, biochemistry, and modeling of dementia disorders, with a major focus on Alzheimer's disease and Lewy body dementia. Welcome, Dr. Dickson.
Okay.
Yes, sir.
Good. Thank you. Well, thank you for the introduction. And I'd like to tell you a little bit about the brain pathology that we have in Lewy body disease. So I think this has been mentioned by Dr. Graff-Radford, that there are different ways of referring to the disease process. Parkinson's disease is a disorder associated with slowing of movement, stiffness or rigidity, and tremor. And Lewy body dementia is also called dementia with Lewy bodies. It has a very different presentation. Dementia, hallucinations, rigidity, and slowing of movements, and also fluctuations. So those are the clinical terms, those are the clinical presentations that we're trying to describe. When we do the pathology of the individuals that pass away, donate their brain for research and diagnosis, we use the terms Lewy body disease, Lewy body pathology, or synucleinopathy, because we can only speculate about from what we find, the relevance to what the patient was like. So there's been an explosion of research on Lewy body dementia. So it was first described in the mid or early 1980s by a very talented and gifted neurologist in Japan, Kenji Kosaka. And in fact, years since, he's recently passed away, people have actually suggested calling the disease Kosaka's disease, but it hasn't caught on. And other major advances were the discovery that you could use markers for protein degradation, which we refer to as ubiquitin and ubiquitination. And this is a quite useful marker for detecting Lewy body disease. In the late 1990s, people using genetic approaches actually discovered that there were mutations in a gene that causes Lewy body disorders. And that mutation was in the gene called synuclein, or SNC SNCA is a term that's used for that. That's a genetic term. And 10 years ago, 20 years ago, we started to get diagnostic criteria that were reliable, and we got very advanced types of studies looking at the genetics of the disorder. So this is just a summary of the changes. Probably isn't up to date, but you can see that there's a great deal of progress made on Lewy body dementia using various different types of techniques such as biochemistry, electron microscopy, or immunohistochemistry. And we reported in 2002 that in terms of our brain bank, after Alzheimer's disease, Lewy body was the most common cause of dementia. And then these were the criteria that were developed for Lewy body disease. And they pretty much haven't changed. In terms of other studies that were done here at Mayo Clinic, I think Dr. Graff-Radford and Dr. Ferman were leaders in this field with Brad Bove in Rochester, recognizing that dream enactment behavior or sleep behavior disorder, or RBD, is one of the early signs of Lewy body disorders. And in fact, it can occur decades before the patients develop the Parkinsonism and the psychotic features of the disease. We've made major advances in the genetics of Lewy body disease. The major risk factor for Lewy body disease is a protein called apolipoprotein E. This is a cholesterol binding protein that's in your blood. We don't know the link between the cholesterol and AD, but they go together. People with high cholesterol are at risk for AD, and they're also at risk for Lewy body disease. And ApoE4 is probably the factor that contributes to both of those things. I mentioned that there were discoveries of mutations in the synuclein gene, the SNCA gene, and this actually was a discovery made by Mayo Clinic investigators of families with Parkinsonism that was diagnosed, but there was no understanding of what was the cause of the familial Parkinsonism. So we now know that you can have mutations in the synuclein gene to cause that familial Lewy body dementia. And then there's several other major genetic discoveries. The LRRK2 is the leucine repeat kinase. This is the most common genetic cause of all forms of Parkinson's disease. And a subset of patients with Lewy body dementia have mutations in this leucine-rich repeat kinase. And then a few other more recent genes. These haven't really stood the test of time, but nevertheless, the work on the genetics of Lewy body dementia continue. So I want to tell you a little bit about our brain banking. And I don't know where this figure came from, but the value of this sample is a lot more than 25 cents. So in part, the value of the brain that we obtain at autopsy is greatly enhanced if that individual had good characterization during life by neurologists such as Dr. Graff-Radford or neuropsychologists such as Tannis Ferman. So with that wealth of clinical information, we do the pathology, do dissection, sampling, look at it under the microscope, and we try to correlate the findings for what was the problem in the brain that is associated with, for example, REM behavior disorder. So, and Lewy body dementia is actually common. This shows a Venn diagram looking at various types of dementia, such as vascular dementia, VAD, Alzheimer's. Alzheimer's is the big elephant in the room. It basically, 42% of all dementia in our brain bank is related to Alzheimer's disease. But a subset of those actually have mixed pathology. So you see 14% have both Lewy body and Alzheimer's. 11% have both vascular problems, strokes or mini strokes, and Lewy body disease. So Lewy body disease by itself can cause the disease, but very often it's associated with other comorbid pathologies. I think I basically said this. The numbers are not up to date. We have many more cases, but let's just say we have the largest brain bank in the world when it comes to Lewy body disease. And they come from all over the United States. They tend to be mostly from Florida and Minnesota because those are the places where the Mayo Clinic has its base. But in fact, we get them from all over the United States. There's an organization, or a non-profit organization called the Brain Support Network. It was developed by Robin Riddle, a caregiver of a patient who died of Lewy body dementia, and she has taken upon herself as a mission to actually help other families get pathologic confirmation. And so a very large proportion of the brains in our brain bank with Lewy body disease, maybe as much as 30–40%, have come through that effort of that one individual. You can see that these have contributed to a number of studies, such as our Alzheimer's Disease Initiative study. And the thing I want to emphasize again is often Lewy body disease is mixed. So in this cohort, 44%, almost half of the Lewy body patients have Alzheimer's pathology. So if we could find, and part of the reason for that is they have the same genetic risk factors. Apolipoprotein E is a risk factor for Alzheimer's and for Lewy body disease. And they both have amyloid deposits and neuronal inclusions. The neuronal inclusions differ between the two, but there's a lot of overlap. So I think Dr. Graff-Radford talked about this already, the characteristic features being dementia, Parkinsonism, visual hallucinations, delusions. And where the pathology is in the part of the brain that's important for control of movement and sleep. So dopamine is decreased in Lewy body dementia and in Parkinson's. And so in fact, the major treatment for these disorders is Sinemet, a form of a drug that replaces the dopamine deficiency. Just a bit about dementia. So some degree of cognitive impairment seems to be almost inevitable with age. There's certain people that age, with super agers or exceptional individuals that don't have any decline with age, but the majority of people have some degree of cognitive decline with age. And so that's not dementia, though. To have some forgetfulness is not dementia. Dementia is defined when that impairment interferes with your daily life. And so it's very important that we make a distinction, and we don't call somebody that has cognitive slowing or cognitive weakness dementia. So terms that have been developed for that are such as mild cognitive impairment, or MCI. And that is a broad umbrella that encompasses even the Lewy body dementia patients in the early stages. So I think Dr. Graff-Radford's gone through these. Just point out that Lewy body dementia is a very heterogeneous disorder. It affects multiple parts of the nervous system, so that the patients end up with cognitive or thinking problems, motor problems, psychiatric problems, and sleep and autonomic dysfunction. Some of these have already been touched upon. Just point out that the autonomic and sleep are probably due in part to overlapping of the neuronal populations that are involved in both those normal activities. The Lewy body is an inclusion body that occurs within the cell, within the neurons. And it actually, in studies by Heiko Brock and Eva Brock in Germany, they looked at a large number of patients with a whole range of Lewy body pathology. And they were able to actually, based on putting all those pieces of data together, to show or to hypothesize that the Lewy body pathology seems to spread. It may not actually physically spread, although there's some evidence that it may actually go from one cell to another. But at least the pathology propagates in a very predictable fashion, where it starts at the lowest parts of the brain in the medulla and progresses through the brainstem and eventually to the cortex. So depending upon where the person is on that pathway, They may present with pure autonomic failure, with Parkinson's disease, or Lewy body dementia. So that it fits with the progression through the nervous system. These are the pictures of Lewy bodies. Lewy bodies with our routine histologic methods are bright pink, round inclusions in neurons. If you'll notice that there's some brown pigment there, this is a characteristic side product of dopamine metabolism. After years and years of producing dopamine, the neurons accumulate this black pigment. If you look at a child's brain, you will not see any of that pigment. So that tells me that those neurons were from an elderly or an older individual. Now, the Lewy body itself may actually be a protective response of the cell to various factors that are contributing to the disease, most or many of which we do not really understand. But in fact, the attempt to react to those forces eventually leads the neurons to die. So in panel B, actually, you see Lewy bodies with their arrow. Those are Lewy bodies that have been left after the neuron has died. So the what we call scavenger cells have the brown pigment is now in the scavenger cells, and the Lewy body resides in the extracellular space. So this is a challenge for treatment, because if they're so insoluble that they exist even when the cell dies, how can you expect to get a drug in there to modify that process? And this is a similar image as the previous slide, except now we're using a special staining method that allows us to see alpha-synuclein. And you see clearly that the Lewy body is intensely positive with synuclein. But what this has actually shown us is that there's far more pathology than just the Lewy body. If you see in panels B and C, all the brown, that represents synuclein that's being accumulated throughout the brain in various processes of neurons. So it's not just the Lewy body, but it's the much more extensive neuritic pathology. So this is that staging scheme I mentioned that Brock developed. And it still is widely used, but the staging then can be broken down into very simple categories, either brainstem predominant or diffuse, and then an intermediate that's between brainstem and diffuse. And the significance of this is that patients with the brainstem type of disease mostly have Parkinson's. They may have sleep disorder and Parkinson's, but they don't have cognitive problems. They don't have the visual hallucinations. In contrast, patients in stages 5 and 6 of diffuse Lewy body, where the synuclein pathology has propagated to other parts of the cerebral cortex, the patients have cognitive problems and hallucinations and the full clinical spectrum. So this really suggests, although it hasn't been proven, that the synuclein pathology propagates from cell to cell in the brain. The other thing about Lewy body dementia, and I think Dr. Graff-Radford mentioned this, is it often occurs with some degree of Alzheimer pathology. And in fact, if you look at the patients, if you look at the Alzheimer pathology in these cases, if you have if you have just brainstem Lewy bodies, stages 1 and 2, then you'll have much less Alzheimer pathology, as opposed to stage 5 and 6, where there's much more Alzheimer pathology. So we have to think of Lewy body dementia as actually a mixed dementia. Alzheimer's is a mixed dementia. The two major proteins are amyloid and tau. Lewy body disease adds another protein abnormality, and that's the synuclein abnormality. And we actually can, it's a difficult task when you look at pathology blinded to clinical history to predict whether or not the person had a given clinical syndrome. And what we've learned over the years is that the more severe the Lewy body pathology, the more likely they had the Lewy body dementia. And the less comorbid Alzheimer pathology, the more likely they have the clinical syndrome of Lewy body dementia. So you see in the bright pink areas where they have high likelihood of having the Lewy body dementia syndrome, they have minimal Alzheimer pathology, stage 0, 2, or mild Alzheimer pathology, 3 and 4, but they have diffuse or transitional or limbic type Lewy body disease. And the Mayo has had a prospective study of Lewy body dementia, and some of those individuals that are involved in Tannis Ferman's study have come to autopsy. And of the 46 cases that were diagnosed using the state-of-the-art clinical criteria, 44 of them actually had Lewy body dementia. Very high accuracy. There are a few that didn't fit. So we had one patient that was thought to have Lewy body dementia during life that actually turned out to have Alzheimer's with multiple small strokes, mini strokes. And we had another patient that had progressive supranuclear palsy. This is where they fall. You can see the majority of the patients fall into the bright red, and there virtually none of them are in the brainstem type. So Lewy body disease, there are various proteins that are involved in this disorder. There's a lot of interest in the role of mitochondria. These are the powerhouses of the cell that generate the energy that keeps the cell alive. And so sporadic PD may be associated with mitochondrial dysfunction. The mitochondrial dysfunction then can trigger other types of brain pathology through oxidative stress. So mitochondria are the energy factories in the cell, and they can, as a side product, produce toxic oxygen species that, especially in a disease state, can be amplified and eventually lead to cell death. And what this diagram shows is that a number of the genes for Parkinson's disease or Lewy body dementia, the ones that are in the circles, like LRRK2, PARK and PANK, DJ1, these are all genes that are involved in causing Parkinson's disease. And they seem to be, many of them, linked to this similar pathway. These are, I think I may skip this slide, genetics. So I want to just tell you about some of the discoveries that were made about the mutations that cause familial Parkinson's disease. This is a very large kindred that was developed by Dr. Larry Golby and Robert Wood Johnson Medical School in New Jersey. And it includes cohorts from Italy and the United States. It's a family tree, and it's actually bigger now. This is in 1996. Having this rich genetic information allowed geneticists to actually identify the mutation that was causing the Parkinson's in this family. And it was a mutation in the gene for synuclein. The gene for synuclein is SNCA. And so this provided really conclusive evidence that there were really strong genetic drivers for Parkinsonian disorders and Lewy body dementia. And then this is the kindred that was studied for years at Mayo Clinic in Rochester. The family was from the Midwest, and you can see the number of individuals, number of generations of people with Parkinson's disease in this family. And using sophisticated genetic methods, this was discovered to be a mutation in which normally you have a synuclein from your mother, a synuclein from your father on the genes. What happened here is you got a duplication, so that you had 3 copies of the synuclein gene. So no other abnormality in the protein, but just too much synuclein leads to the disease. And this was discovered, I think, serendipitously, but cerebrosidase is a gene for Gaucher's disease. This is a lysosomal storage disease that affects young individuals. But it was discovered that a number of these individuals actually had Lewy body disease. And the gene for Gaucher's disease is glycocerebrosidase. Interestingly enough, if the individuals with Lewy body disease had an increased frequency of variants in the glucocerebrosidase gene. The disorder that they had looked like typical Lewy body dementia. And then this other gene, this is a gene that's called leucine repeat kinase. This gene was actually discovered here at Mayo Clinic in Florida as a cause for Parkinson's disease. Interestingly enough, individuals that had this mutation had various types of pathology in their substantia nigra. Some of them had synuclein, like typical Lewy body disease. Some had other types of inclusions, like that were positive with ubiquitin, with proteins that are undetermined, and some of them had tau protein. This suggested that perhaps if we learn more about LRRK2, we could learn more about the whole universe of Parkin. And this was actually published in a Neuron, a journal, high-profile journal. And in fact, the image that you see there was actually going to be on the cover of the journal, which was we were really excited about that. But in fact, the editor passed away, and the cover was simply a white cover with just the title Neuron, nothing else. So we lost to a good cause, I think, to acknowledge the contribution of that individual. The paper was published, and it represented the first report of a gene that can cause different types of Parkinsonian disorders. This is from our autopsy series, and some of them have nonspecific pathology, some of them have Lewy bodies, some of them have tau pathology. And we've actually looked at almost 2,000 brain samples for the frequency of this mutation. We found 12 cases. The most common mutation is G2019S. The interesting thing about this mutation is it's enriched in Jews and in Arabs. So even though they're fighting between themselves, they're actually relatives. So this is the most important gene for Parkinsonian disorders. The majority, I mentioned, have Lewy body disease, but some have tau pathology. So this is the most recent gene. I think it will eventually stand up. There's a gene that is involved in protein synthesis. It's called EIF4G1. This is also a gene that's associated with Parkinson's, and you can see it affects several generations, not like the big Contursi kindred with 10, 15 generations. This is like maybe 3 generations, 4 generations. Nevertheless, it's enough that with linkage studies and modern genetic methods, you could actually identify what that gene was. And that was the EIF4G1. So just to summarize, the Lewy body dementia is the second most common cause of dementia in elderly after Alzheimer's disease. And pathologically, it's not simple. Most patients have both Lewy body pathology, but also some degree of Alzheimer type pathology. Clinically, there are a number of very characteristic features of Lewy body dementia, such as dream enactment behavior, which is associated with REM, RBD. And in fact, some of these features can be prodromes of the disease. People can have sleep disorder for decades before they actually start to develop the Parkinsonism or the cognitive impairment. The other important thing to know is that Lewy body dementia represents kind of an overlap between Parkinson's on one hand and Alzheimer's on the other, both in terms of the pathology, the clinical presentations, and their underlying genetics. And we just want to emphasize again that apolipoprotein E, this is the most common gene for both Alzheimer's and for Lewy body disease. So I'll close there.
Thank you, Dr. Dickson. Again, if you have any questions for Dr. Dickson, please write them on your note cards, and those of you joining via Zoom, please send them through the chat. Our next presenter is Dr. Tannis Ferman. Dr. Ferman is a board-certified clinical neuropsychologist and professor in the Department of Psychiatry and Psychology at Mayo Clinic in Florida. She earned her doctorate from Rosalind Franklin University, Chicago Medical School, completed her internship at the University of Chicago, followed by a fellowship at the Mayo Clinic in Rochester. Dr. Ferman has been on staff at the Mayo Clinic in Florida for over 25 years. She is a co-investigator for the Mayo Clinic ADRC with an emphasis on Lewy body disease. In 2015, 2004, Dr. Ferman has served, since 2004, Dr. Ferman has served on the Scientific Advisory Board for the Lewy Body Dementia Association. Welcome, Dr. Ferman. You can use a mouse, can I? You can. This one? Yes.
Thank you. Thank you, Sushenda. I wanted to thank Sushenda for organizing this and all the ADRC staff who really make everything happen behind the scenes and are so great about it. I'd like to also thank Dr. Graff-Radford, who I've worked with for now 27 years-ish, and is just a wonderful advocate for his patients and wonderful to work with. And Dr. Dickson, who is very modest, is really one of the very first discoverers, if you will, of Lewy pathology, Lewy-related pathology, and really a tremendous colleague and friend. So I would also like to thank our patients and loved ones of the patient, our patients, your loved ones, and caregivers who are here today and online as well. We want to provide information for you and support, and also provide a community to share and help you through this. I will call it a journey, but this process of this disease called Lewy body dementia. So what I'm going to do is talk a little bit about what this disease is. Dr. Dickson and Dr. Graff-Radford already did that, so I'm not going to belabor it. My main focus is really to kind of today talk about, so now what? Now what do you do? So we have this, we're dealing with this day to day, and how are you supposed to respond? What are you supposed to say? How are you supposed to manage this on a day-to-day basis? So this is just a summary of the criteria. All patients with DLB, with Lewy body dementia, have cognitive difficulties. That is a requirement. The core features are listed below, as have already been described. And you can have one, you can have two, you can have three, you can have all of them. And as both my colleagues mentioned, it's pretty heterogeneous. Some people have one or two, some people have all of them. So it can present in a variety of different ways. But the stages or the process in which this occurs it does occur in a certain kind of pattern. We don't just wake up one day and all of a sudden have dementia, or all of a sudden wake up and now I have all of my symptoms. This is something that occurs over the course of many years. This is, the brain changes don't occur overnight. They actually occur, as my colleagues mentioned, as Dennis and Neil mentioned, 20, 30, 40 years before the first clinical core symptoms of even the cognitive changes start. I have patients who will tell me, well, on our honeymoon, I wondered what I got myself into because he was kicking and shoving and screaming and I, had to run out of the room. So RBD, REM sleep behavior disorder, can occur decades before the initial cognitive changes. Another thing that can happen is loss of sense of smell can occur also many, many years before the very first changes, the first cognitive changes can occur. So the very first changes can be what we call preclinical. In other words, there's normal aging, and yes, there are normal changes that occur with age. I'm a neuropsychologist. I assess people's cognitive function, and we use norms because that tells us, okay, compared to other people your age, where are you at? Is this normal forgetfulness, or is this a little more than we would expect for someone your age? And so you can see there is normal aging changes in cognitive function. People who have REM sleep behavior disorder can be perfectly cognitively intact for many, 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 many years. And in fact, we have some patients who've come to autopsy who never developed cognitive symptoms, never developed Parkinsonism, but in the brainstem had synuclein or Lewy body disease. In other words, the synuclein developed inside the neuron or inside the processes that connect between the neurons. That's called synuclein, and that showed up in the brain even though they didn't really have any of the other symptoms. Okay, so that can happen. As the disease, as the synuclein builds up, and I have this little kind of picture here, I'm not sure you can see. No, it's not gonna. So I wanted to show, well, in the top, can't really see it for some reason. Let's see if I can get this to work. No? Okay, well, and you see the blue and the red in the top. So the red is what's called misfolded synuclein. The blue is, regular normal synuclein. We all have synuclein. Everybody has synuclein. It has a job. It's a protein. Our proteins do stuff in our brains. But what can happen is when a synuclein or when the protein misfolds, it's kind of a bad influence on the other synuclein, and it can transfer, it can actually misfold, it sort of brings them over to the wild side. And what happens is now we have, instead of one misfolded synuclein and one regular normal synuclein, we now have two misfolded synucleins, and then they go off and they tell two friends, and so on and so on and so on. So that's one of the theories, one of the ideas of how it spreads. As Dr. Dickson mentioned, we think it can actually spread from neuron to neuron to neuron. So anyways, when that happens, then we can have a buildup of other brain areas that are involved. And then we get into what we call the MCI stage. That stands for mild cognitive impairment. Mild cognitive impairment means there are cognitive changes, but you're getting around it. You're doing okay. You're managing, you're getting what you need to get done, you're doing okay, but there's clearly, when we do our tests, a change in your cognitive function. That's what we call mild cognitive impairment. When your cognitive skills get to a point where it's just too hard to keep it up, and it starts to interfere with day-to-day, your independence, your ability to manage activities of daily living on your own, the ones that you normally would manage on your own, that's called dementia. Okay, so you can see that this is the pattern that we can follow in understanding. We have the dementia stage, but we also have what we call the prodromal stage, or the MCI stage, and even the preclinical stage. And as Dr. Graff-Radford mentioned, we now have these biomarkers. We have a skin punch. We have this spinal tap that we can do. We're actually starting to identify people more and more and more in the preclinical and in the MCI stage, with the idea that when we have something that can stop this progression, we can stop it earlier. We can stop it before the dementia stage. And that's what we're endeavoring to do. And that's what our basic scientists are doing. And that's what the clinicians are working with our basic scientists. That's our goal. So, what are the cognitive issues? So, Alzheimer's disease is predominantly a memory issue. In the MCI stage, it's a memory problem. Trouble recalling what was said, trouble recalling what we did recently. It's, did that conversation take place? I don't remember having that conversation. It's the whole, well, I told you that already kind of experience that we can have sometimes with our loved ones who have Alzheimer's disease. When people have Lewy body disease, they may have a little bit of that, especially if they have Alzheimer's mixed in, but by and large, what it is attention and visual difficulties. So processing speed is slower, attention is a problem. And so when people have Lewy body disease, now we all do this, you're all going to think, wait a minute, we all walk into a room, oh wait, what did I come in here for? Or we'll get an idea and, what was I going to say? We all do that. Okay, we all do it, we all do it. People with Lewy body disease do it a lot. Okay, they do it a lot to the point that it's almost like, some people will even tell me, I don't even bother because I can't even get, once I get to start to do something or say something, there's no point. It's just frustrating. Okay, so losing train of thought super easily, that's a feature of Lewy body disease. The other feature is visual problems. And a lot of my patients will say, well, I can't see properly, but my eye doctor says my eyes are fine. Well, that's good. Please go to your eye doctor and check it out, because we want to make sure that your eyes are fine, because that gives us information that maybe it's a brain issue and how the information is processed, and not necessarily an eye issue like cataracts or macular degeneration or something like that. Now, attention and visual problems occur in dementia with Lewy bodies, or I call it Lewy Body Disease because that kind of combines the Parkinson's disease with dementia as well as the dementia with Lewy bodies. Can you get memory problems? Absolutely, because sometimes people with Lewy body dementia also have Alzheimer's mixed in, so you have both, okay? How do we tell someone apart? How do we know if someone only has Alzheimer's disease versus maybe Lewy body dementia with Alzheimer's disease? And in fairness, the answer is early on, the processing speed, attention, and visual problems are much more significantly affected in Lewy body than they are in Alzheimer's, and this is a graph to show that. So the red line is Alzheimer's disease, the blue line is dementia with Lewy bodies, and these are just some tests that we give, and just to show you that worse functioning for attention and visual for the Lewy body patients, whereas the Alzheimer patients do a lot better. And then it's flipped. Patients with Alzheimer's disease do really not so great, really, this is early disease, mild. Poor memory, and also what we call poor object naming, and that's sort of a pulling up from memory the names of things. What's that name, that thing you write with? That pulling up the memory of that name. And then for Lewy body dementia, those skills, memory and naming, tend to be much better. Not necessarily perfect, but better. So Dr. Dickson talked about this a little bit, and I just want to mention it. There is sort of seems to be a progression of this synuclein, and it deposits, and I want to make it, the first brain here is sort of that bottom-up progression that Dr. Dickson mentioned. When somebody has REM sleep behavior disorder, sorry, I can't get my, I wanted to, no? Okay, it's not going to work. I wanted to point out, but the lower part where the arrows are, the very bottom, that's an area that's affected first, and that's where when the Lewy body pathology builds up there, that's where it disrupts the brain regions important for acting out dreams. It's important for keeping your muscles paralyzed during dream sleep. And when you don't have that paralysis, you'll act out your dreams, okay? Also, the autonomic area is in that brainstem part. So maybe someone who has a lot of trouble regulating blood pressure, and they might lose, get drops in their blood pressure and get real woozy. That can happen with brainstem involvement. And then the Parkinsonism is also in the top part of the brainstem. That area is important. Those brain regions are important for Parkinsonism. And then in the middle part of the brain, in the middle area, that's where where it's important for attention and hallucinations and fluctuations in that middle area. Okay. People who have the bottom-up progression, they often will meet criteria for Lewy body disease earlier. They'll get diagnosed earlier because they often have RBD and Parkinsonism. But there's another type of progression. We call it the limbic-centric progression. And these folks might have more of the middle part of the brain affected first, and then the brain stem sort of affected later. And so what happens is there'll be attention problems and vision problems and maybe even hallucinations, and the person may or may not have Parkinsonism. So you can imagine if you don't have two of the symptoms that are the features, you might not get diagnosed as readily or as quickly. And so that can happen. Okay? Oops. Sorry. Sorry about that. Okay, so summary. These are the core features, includes cognitive and those 4 clinical. So now what? So now I want to shift focus and talk a little bit about what do you do? What do you do now? So one approach that I like to make sure that everybody is aware of is just focus on the emotions. Focus on your own feelings when something is happening, and focus on, put yourself in their shoes, on your loved one's feelings. Now, this is probably true for life and for any type of relationship. It doesn't have to be caregiving or dealing with, dementia or cognitive problem. But if you identify how you're feeling, what are your feelings, and you label it, that will help you to know what's bothering me. You know, if your loved one thinks that there's somebody living in the ceiling and you find it humorous, great. If you find that just absolutely so annoying and frustrating, know that, because that tells you, okay, that's how I'm feeling about it. And then look at your loved one. Is it bothering them? Do they find it entertaining? I had one patient who used to see dancing girls, hallucinations of dancing girls. Didn't bother him. He found it quite entertaining. Another patient used to look across the outside and it seemed like circus tents were going up, and his wife was just like so upset by it, but he found it fascinating. Look at those circuit tents. I wonder what they're going to do. She was frustrated. She was annoyed. He was kind of curious and interested. So look at the emotions and where do we need to address it? And often I'll talk with families, and the question is, how upsetting is it to the person who's experiencing the hallucination, for example? If they're not bothered, you don't need to worry about it. It doesn't need to be treated. The only time we really need to treat something, a symptom, is if the person is upset. Really, that's true in life. You know, we just go along and things happen to us, but we only really need to address the things we're upset about. So if you're the one that's upset about it, then that tells us, well, maybe we need to give you an antidepressant because he's not bothered, but maybe it's bothering you. That tells us, or maybe it's time to get someone else in, you're overwhelmed, it's too much, time to bring someone else in. That gives us a direction based on the emotion, okay? Also, validate the feelings. If someone is upset, instead of trying to talk them out of it, just rephrase what they said or identify. That's really frustrating. My dad's 93 years old, and I was talking to him on the phone the other day, and he has his own kind of style of doing things. And I find myself doing this with him all the time. Wow, that sounds really frustrating. That sounds really hard. And he feels heard, and I call it the smile and nod approach. Like, just agree and, validate, and he feels heard, and okay. The second step is solution focused, and this is sort of the more looking for the patterns, looking for the triggers. When does this happen? Who's around when it happens? Who's around when it doesn't happen? I often will have people tell me, well, my sister, he only does it around her, he never does it around me. Well, what are you guys doing differently? Does that give you a clue? Is she rushing him? Are you more patient? What's the difference? Where does it happen? It only happens in the living room. It only happens, so just sort of look at the kind of the patterns and the triggers. And then these are just a list of the solution options to consider that I'm going to go over in a minute, okay? So I'm just going to go step by step with each clinical feature. REM sleep behavior disorder, just very quickly, it's not psychiatric. In other words, even though someone might be dreaming of fighting or might be dreaming of the war, it doesn't necessarily mean that they're, have some unresolved psychiatric issues. It's a neurologic condition. What we're dreaming is what our emotions are at the time. It's not seizures, it's not sleepwalking, it's not sleep apnea, and it's not restless legs, but all of these conditions can make it worse or can mimic it. So it really is helpful to go and, if someone might be having nighttime seizures, and sometimes it is a good idea to get an overnight sleep study just to rule that out. Or sleep apnea can sometimes look like fighting during sleep, and treating the sleep apnea can just solve that problem. Dr. Graff-Radford mentioned antidepressants. Some antidepressants can trigger it and make it worse. So just knowing that. What do we do with RBD? Move things that are sharp out of the way. Some people will lower the bed. Sometimes people find a body pillow helpful. And to be honest with you, sleeping in separate rooms is often the best solution from a solution focus here. Physical, in other words, what are some physical or physiologic things we can do? Melatonin's useful. Clonazepam, for reasons we don't understand, can mute some of the movements and can help a lot. And frankly, treating the sleep apnea can also make a big difference. Communication. So what I mean here is, in this context, is, what can make it better? What do you say? Now, you're not going to talk to your loved one who's sleeping, but I have many, mostly wives, to be honest with you. Women, when they act out their dreams, are knitting and doing nice, quiet things like kneading bread, and men are fighting and throwing themselves around and, punching, and that their dreams are a little more vigorous. Unless safety's a concern, try not to wake your loved one. And here's why. If you repeatedly wake your loved one, it's disrupting their sleep, but it also is disrupting getting into REM sleep. And what can happen is our bodies want REM sleep. And so what'll happen is there'll be REM rebound. And so when they go back to sleep, they'll go right back into REM, and it's like this, constant perpetual cycle. So it can really disrupt your sleep even more. And this is why going to another room is a good idea. Also, if you don't get enough REM sleep, not only will it worsen RBD, can of course disrupt nighttime sleep continuity, cause sleepiness, but can cause an intrusion of dream sleep into wakefulness, and can be one of the reasons why visual hallucinations can occur. So if safety is not an issue, go to another room, just try not to wake up your loved one. Parkinsonism, these are all pretty standard. I'm just going to zip through the Parkinson stuff reasonably quickly. Sort of obvious stuff, right? Remove throw rugs, grab bars. There's a very extensive amount of literature, research. Dr. Graff-Radford's done some of this, looking at exercise on improvement of function. And, exercise means any kind of activity. It's not like you have to go run a marathon. Any kind of activity. And then medication. Is levodopa, carbidopa appropriate? Are there some medications that the person is taking, maybe some anti-nausea medicines, that could be making it worse by lowering dopamine? So those would be the physiologic reasons to address. In Parkinsonism, one of the things that we know is that people are slower. The attention problems certainly co-occur in Parkinson's and with the Lewy body. And just, break it down. The task demands can be broken down. Focus on what the person can do. And it may just be there's too many steps to a task, and you have to just provide instructions one at a time. Set aside more time. Have a plan. Have a daily routine if you can. And one of the things that I will often notice is, and this is true for not just people who have Parkinsonism, but in Lewy body in general, is that you'll notice your loved one might be a little bit more of an observer than a participant. That's okay, especially in group settings. It just might be too much to keep track of. Communication. I don't know if you can see this Parkinson pocket guide to decoding a Parkinson face, but all the expressions are the same. If you are wondering if your loved one is upset or depressed, you have to ask somebody with Parkinsonism, because you're probably not going to be able to read their facial cues super easily. And those of our patients who have this, let us know if you're not feeling, well, or if you're down. Slow down, one request at a time. Write things down. And those are the suggestions for Parkinsonism. Okay. Well, now I want to talk about fluctuations and visual hallucinations. What are fluctuations? I think that the patient's wife that Dr. Graff-Radford showed us the video of really described it beautifully. I'm just going to explain how I view it. This is a variability in attention and alertness. So everybody has their normal ups and downs, and we all have our good times of the day and our bad times of the day. I used to have a professor who would only schedule certain things on his good times of the day, which for him was in the morning. We all have our times when we're a little better, a little worse. People who have Lewy body disease, it can dip, and so they can still have their fluctuations, but what will happen now is it can affect alertness. Patients will feel sleepy. Our caregivers will say, well, he's zoned out, he's not with us, he's somewhere else. Drowsy, we did a study a while ago that showed patients with Lewy body were sleepier. They just slept more. Speech can be less coherent. Sometimes what'll happen is a person will start telling you something, but you're not sure what's the context, and they're maybe starting mid-thought or starting to tell you something in a way that just doesn't really make sense. It's not aphasia, but it doesn't really make sense. And they may just be 2 conversations behind. And then losing the train of thought, which we already talked about, but that can be important in multi-step tasks or knowing what to do first, what to do next. And so what will happen is patients will maybe have trouble doing something that they could do a few moments ago. And I have caregivers who tell me this is the "are you kidding me" symptom, because you could just do that, and now you can't, and then you can again. And there's this, I don't know how to plan anything, because sometimes you can do it and sometimes you can't. So how are you coping with that? It's really frustrating. So take out your emotion thermometer and ask yourself, how am I doing here? What causes it? Well, there's an area in the brain called the nucleus basalis of Maynard that produces this brain chemical called acetylcholine. And acetylcholine is really, really important for attention and wakefulness. And it projects throughout the entire brain. And the cell loss, when we lose that acetylcholine, we also kind of disconnect or lose our ability to modulate the other parts of the brain. And people who have Alzheimer's disease also have damage to this area, but people with Lewy body disease have it more severe and much earlier. Okay, and so that's why that donepezil, which boosts the acetylcholine, helps so much, because the area of the brain that's affected is the area that produces that brain chemical. So, fluctuations, what do we do? Well, firstly, anything that's physiologic is going to make it worse. So if there's pain, if there's a bladder infection, there's constipation that's really not well controlled, dehydration, alcohol use, cannabis use, which is becoming more common. I have to put it on the slides now. Sleep apnea. Those are all things that can make it worse. Someone gets pneumonia, I guarantee you their fluctuations are going to be a lot worse. Once you treat the pneumonia, it'll be better. Anticholinergics are really, really important, and I'm just going to say, please don't ever take diphenhydramine. It's over the counter. It's the Benadryl, sleep aids, those medications that are just really good at being antihistamines, and can cause drowsiness, but for someone with Lewy body can really lower the cholinergic or the acetylcholine and can cause confusion and hallucinations. It can make it all worse, okay? And there's lots of other prescription medicines that can be anticholinergic as well. So ask your doctor, are any of these medicines anticholinergic? Because that, I know, can worsen Lewy body, okay? And then sometimes consider stimulant if it's appropriate, or even an antidepressant that's activating, and including activity or exercise in the daily routine. Exposure to sunlight can actually make a huge difference, and I know that seems so ridiculous, but it actually can reset the circadian rhythm and can make a big difference in fluctuations. Also, having a routine. A lot of my patients, caregivers will say, well, it's just here or there, I can never predict. And that may be very well the case. But if you always try to have the same routine and kind of look to see when is, mornings are better, so mornings would be the time to do things, and then schedule downtime in the afternoon, or vice versa. But it can almost train the brain a little bit, like we have scheduled downtime, scheduled outings. And the other thing, and I included this in the environment because I wasn't really sure where to put it, is just widen your team. So you don't have to do this alone. You shouldn't do this alone. It's not really feasible to do it alone. So is there a day program? Is there a family member or family members or even volunteers that can sign up to come in and help out? Can you hire in-home help? Is there an exercise trainer? Just physical therapist, in-home, rehab, any kind of time where you have other people that can come in and kind of, engage with your loved one can make a difference. And one reason is that one of the things that patients, family members will always tell me is, oh yeah, we're at home, he's staring off into space, can't function, but we go to see Dr. Graff-Radford, and he's walking, and he's talking, and he's lucid, and the wife is like, oh my gosh, this is not what he's like all the time. And this, we know this happens, and it's sort of a rise to the occasion. I had one caregiver tell me it's showtime, whatever you want to call it. It's just a boost of adrenaline, a boost of that energy. It's like a stimulant, kind of like a good latte or something like that, espresso shot. And, so capitalize on that. If you know your loved one perks up around others, then have others help. Even if they're like, oh, I don't want other people. Once you get into the routine, it will just be part of the routine. Attention and alertness can, as I said, affect all other functions, all other abilities. And so when we have certain task demands, if we're not stimulated enough, if something's too easy, we don't do so great. We're sort of like, oh, I don't feel like, we don't do well. But if we're also asked to do something that's too hard, we also can't do it. So that's where, looking to see what can the person do, break down the task, and if you can, avoid too many details at once, because remember, it's keeping track of details. That's part of attention is really hard. So if you're frustrated because you asked your loved one to do 5 things and they didn't do any of them, or they only did 1, okay, maybe just 1 at a time, or write down 2 things, or kind of break it down. And here's, I think, the best advice: do the dance. There are going to be times when you're going to have to step in and help, and there are going to be times when you have to just back off. And you're going to have to step in and help, and you're going to back off, and that is the nature of fluctuations. And there will be other times where you just got to just go to the other room and just let it go. Okay, getting there. Visual phenomena. I grouped all these together because there's so many, and they all kind of address the same issue. The visual difficulties are caused by changes in the brain that affect visual processing. Day to day, it can be, you can see it where someone maybe is looking for something and can't find it. It's right in front of them. Or certain hobbies that are visual, or your loved one used to do all the repairs and now they just, it's really hard. Figuring out the remote control or the smartphone, all the icons, that can be, how visual problems contribute to difficulties in Lewy body. Visual misperceptions are super common. They occur in about 75% of patients with DLB. We all can see these, oh, that looks like a face, and the angry backpack, and that shadow is a face that looks rather sinister, and that towel looks like maybe it's a person or maybe even an animal. So that happens. We can all see it. This is the visual perceptual problem that people with Lewy body can have, and that can sometimes be mistaken as visual hallucinations, but they're not, they're misperceptions. And so asking questions about what is it that you're seeing, show me, you might be able to say, oh yeah, I can kind of see, that does look like a person. Hallucinations are fully formed images that are not actually there. They occur in about 75% of patients with Lewy body, more frequent in women than men, but they do definitely happen in men. And people with visual hallucinations also have visual misperceptions. So you can have misperceptions and never develop visual hallucinations, or you can have visual hallucinations and visual misperceptions. And Capgras, as Dr. Graff-Radford mentioned, is a belief that a loved one is replaced by an exact duplicate. And I have many examples of patients telling me, well, there's 3 versions of my wife. There's the nice one, the annoyed one, and the one that sits at the computer. Or there's the nice one, the mean one, and the one that flits around like a bumblebee. So, I mean, it's intermittent, so sometimes they are aware that, I don't always recognize who she is. It can depend on, generally people who have this are more further along in the dementia, and it is a little more common in people who also have Alzheimer's mixed in. People who have capgras almost always also have visual hallucinations, so they'll have the misperceptions, then a subset of those people will develop visual hallucinations, a subset of those people will develop capgras. It doesn't mean that everybody's going to develop it, but that's how generally what we're seeing. Okay, what do you do? Well, remember the emotion. Listen, acknowledge feelings. Ask them questions. What are you seeing? Show me. Where is it? Because it may be a misperception and not a visual hallucination. It may actually be kind of cool or humorous or interesting. And ask yourself, whose problem is this? Who's really upset by this? If I'm the one that's more upset than he is, okay, then maybe I need to just, come to terms with this or, manage it. If he's more upset, then I need to address the emotions. What do I need to reassure? Not so much what he's saying, like, no, there's nothing there. Don't feel like you have to address what they're saying, but it's the underlying emotion that you need to address. Wow, that sounds scary. Well, okay, there's a thing called adaptive paranoia, where if somebody feels that they are experiencing something that is upsetting to them, they might do things like, oh, someone's looking in my window. I'm going to go lock all the doors. I'm going to go sit and make sure that, with my baseball bat, that's adaptive. If you thought somebody was looking in your windows, you might try to, okay, what do I need to do to protect myself? So it's addressing the emotion. Well, I checked all the windows. I reassure them based on the feelings, not necessarily based on what they're actually, telling you they're experiencing. And then again, the solution-focused approach. When does it happen? Who's around? If you have somebody who is seeing something through the window, take a look. Oh, I had one patient who saw someone looking through the window, but it was just a tree. And so we moved the chair so that they didn't look at it right on, and then that problem went away. So, that's a solution. We already talked about the physiologic, same thing. This is all the same things for visual difficulties that I mentioned with the fluctuations. Task demands, same, you'll see the list here. It's pretty much what I was describing with the fluctuations, very similar. Schedule and routine, very important. Move the item, move the chair, reduce clutter, turn a light on, sunlight exposure, and honestly, if it happens, it's just great to just say, hey, can I get your help with something, and just leave the room with them. Let's go do this together. Oh, we need to go on an outing, or we need to, I want you to take a look at this over here. And, sometimes just, especially if it's happening in one room, that will help. If it's sort of time of day, that might be a good time to, go on an outing on that time of day. Here are some do's. If you have a loved one who's got visual hallucinations or capgras, appreciate their reality. It may be different from yours. Be aware of your own nonverbals, and what I mean by that is when we get angry, we may not realize that our loved one may mirror that, and so we may be annoyed and then annoyed because they're annoyed, but we need to realize that our face may be conveying information. Listen actively, ask questions. Is it bothering you? You respond to feelings. And frankly, just join in and offer to help. Well, I'm going to go check the doors. I'm going to make sure everything's okay. Yep, I called, and our neighbors are not patrolling with guns or whatever it is that they're seeing. Go along to get along is probably the best advice I can give you. I had a patient once who used to sit in his kitchen with his wife and would turn to his wife and say, the service in this restaurant is terrible. And his wife was wonderful. She was like, I know. Well, we'll just, good thing we have a tab. We can just, we've already paid. So she didn't correct him. She just sort of went along with it. And, a lot of times people will worry, like, oh, are the children in the corner, are they going to get picked up? Oh, yeah, they're going to leave soon, no worries. Again, focusing on what's real to your loved one is more, and reassuring what say what they would need to hear to feel reassured. Don't feel a need necessarily to correct or quiz or, do that. And redirecting to old memories is a really good strategy as well. Other topics, asking for help. Hey, did I ever tell you that, do you remember da 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 da? And then, you moved on. Same with capgras, very unique, specific situation. Here's just some specific techniques or strategies that can be helpful. Refer to yourself in the third person. Oh, are you looking for your wife? Oh, she'll be back soon. Were you looking for me? Your amazing husband, here I am. Sometimes just announcing yourself can help. Ask about yourself, but be careful if you don't like what you hear. That's okay. And apologize. A lot of times just apologizing, and that's true in any interaction when someone has a dementia or the reality is different and they're frustrated. I'm really sorry, I'm sorry. Or, even taking responsibility. I think I might have forgot, let me check, I'm going to look for you. Okay, so those are some suggestions. And this is my summary slide. Just focus on the emotion in terms of your own feelings and your loved one's feelings, and consider these solutions. Thank you.
Well, thank you to all of our presenters. I wanted to take a few minutes for the presenters to come up on stage. We do have several questions from our audience as well as those on Zoom. And we have some chairs here that Anton will help. We've got 3 chairs. Thank you. Thank you. All righty.
What about applause for all my staff who put this on?
All righty. So our first question. The clinical trials that you mentioned, this is for Dr. Graff-Radford, do those studies require imaging tolerance by the participants? So in other words, are those with claustrophobia tolerance ruled out?
You have to look at each one. We aren't taking part in those 3 studies. Rochester took part in 2 of them. They're not entering. They're going to be a phase 3 study now. So if you go on clinicaltrials.gov, you can write this down, clinicaltrials.gov, and put in Lewy Body Disease, and put phase 2 or phase 3, you'll have all the details you want or need. So clinicaltrials.gov.
Okay. Next question. For definitive diagnosis of Lewy body dementia and/or Alzheimer's disease, what are the best practices if patients are intolerant to imaging due to claustrophobia and adverse reaction to anesthesia?
I'll take this one too, clinical one. So the diagnosis really largely rests upon the clinical evaluation. We don't really need imaging as much in Lewy body disease. Also, we can, you saw that Dr. Ferman and myself together are pretty good when Dr. Dickson reports our pathology. What did we miss? 2 out of 44, which was pretty good clinically. So if you have people who are knowledgeable about Lewy body disease, we can make the diagnosis fairly well clinically. We can now do skin biopsies and spinal tap tests looking for confirmatory biomarkers, and that's optional when we're uncertain. We don't need that most of the time. We don't do that invariably. We will need that perhaps when we get treatments, and you have to have a specific diagnosis. Like in Alzheimer's now, we have to know that it is Alzheimer's with biomarkers before we'll start a dangerous drug, the monoclonal antibodies. So we have to know the diagnosis. And so in Lewy body, I think it's we can be pretty accurate clinically, but there are going to be requirements to have biomarker confirmation.
Thank you. And this question is for Dr. Ferman. What is your advice for encouraging someone who is reluctant and overly self-conscious to keep their neuropsych testing appointment to help establish the baseline and identify strengths and areas that we can help?
Well, that's a great question. Getting your loved one to the appointment is probably the hardest part. Once they're there, usually we'll meet with them and you, and almost always my patients will say, that was nowhere near as bad as I thought it was going to be. So honestly, I think just, reassuring, it's not, we do say 4-hour slot. We never trust you for 4 hours. So we have the time allocated in our schedule, but it's usually a lot shorter than that. And usually I encourage people to try the foot in the door. Well, let's just go check it out. And if we don't like it, we'll leave. So you kind of, just foot in the door it and see if that helps.
Okay. This question is, loss of hearing, does this play a role in dementia?
I can answer that one. It's becoming increasingly more important, this hearing and its association with dementia. So in the Lancet report, they report that 44% of dementia can be prevented, and one of the items they put in is treatment of hearing. And they cite a lot of observation studies, and now there are some randomized prospective studies where they've treated hearing versus not treated hearing, and the primary outcome was negative actually, but the sub-analysis seemed to support that it actually is helpful. You can understand that people who have poor hearing isolate themselves. They don't want to mix, and that is one thing. But also, they are deprived of a lot of stimulation. And stimulation, like keeping your mind busy, is actually very important in your brain, in keeping your brain healthy. So it applies not just for hearing, but for vision now. They added this year in the Lancet report that vision is also an important factor. So I think that's certainly one of the crucial things. And I'm in favor of early intervention, not waiting till the person is deaf as a doorknob and just won't understand anything and refuses to do anything. Start early. And, people wear glasses without any trouble. But there seems to be this terrible feeling, something's wrong with you if you have a hearing aid. Can you see my hearing aids? There you go. I'm wearing them, and you can't see them. So this day and age, they really are pretty good. And I strongly encourage people to do that.
Okay.
You outed me.
Our next question is on donepezil. So donepezil slows down the disease, but what is the efficacy over time? Do you know the percentage of efficacy?
Yeah. So it doesn't slow down the disease. That's a misconception, but treats symptomatically the disease. The disease continues. It doesn't affect the progression of the pathology, but it is dramatic when it works. I'm going to tell you what I think, and then I'm very interested what Tannis also sees all our patients. So we have a sort of a bird's eye view of the patients. I think that when we make an accurate diagnosis of Lewy body, maybe 40, 50% respond very nicely for a while to donepezil, but not forever. We are always a little disappointed when a few years later we see, and our phrase is, the person seems to fall off the cliff, because there is a sudden deterioration of people that have been hovering very nicely for a while. We often up the dose for a while, which may rescue them for a while, but it doesn't last for a long time. I think the longest we've had is several years. I'm going to say 3 or 4 years of stabilization. But that is a long time. I think it's more likely a few years. I'm not going to say each person's different, but it's a few years.
Well, as Dr. Dickson can attest, the progression of the disease is, of course, neurodegenerative, and as we said, it affects the neurons that produce the acetylcholine, which is what the medication donepezil addresses. So, if there are no more neurons producing the acetylcholine, then it's going to be a lot harder to, the way that donepezil works is it doesn't just replace acetylcholine, it increases the availability of the acetylcholine that's left, okay? And so I agree, it can be incredibly useful. I will say, though, that for some patients, in the later stages, they're told, don't worry about being on this medicine anymore. And so they'll go off it, and there will be it was doing more than they thought. It just wasn't to the degree that they would have liked, but it did seem to be helping. So we do generally recommend, I know Dr. Graff-Radford generally recommends that we just stay on that medicine as long as possible for that reason, because it may not be helping to the, it might not be fixing things to the degree that we'd like, but it does seem to be doing something. Agreed.
Could I just comment that there's a nucleus in the brain that produces the acetylcholine called the basal nucleus of Minor. And in fact, that is one of the most vulnerable areas of the brain for Lewy body pathology. So the reason that the anticholinergics or the cholinergics might work is because there's loss of those neurons. And it's, the degeneration first, the Lewy body, and then death of the neuron that had the Lewy body. So as the disease progresses, it's going to be more difficult to replenish the deficient acetylcholine because the disease progresses. It gets worse and worse in terms of the neuronal population. And in just a little aside, the nucleus basalis is actually where Lewy first described Lewy bodies. It wasn't the dopaminergic neurons in the brainstem. So this is a very important nucleus in the brain for active thought processes.
Just a few more. So this one is, my loved one was first diagnosed with FTD for about 6 years. They are now diagnosed as Lewy bodies with Parkinson's. How close are these two diagnoses?
So the clinical symptoms are sometimes difficult for clinicians to interpret, and you can make the diagnosis incorrectly, and eventually, as time goes by, you make the correction. You saw that Dr. Ferman and myself called a patient Lewy body, and the patient had progressive supranuclear palsy later on. So we actually recognized that clinically that the person had changed, but our first diagnosis was Lewy body, which is what is fair for Dr. Dickson to count. What's your first diagnosis? Anyhow, the typical symptoms of FTD and Lewy body don't often overlap. If you pay attention to, for example, hallucinations is not a feature of FTD, and REM behavior disorder is not a feature. Parkinson's can be. So you can have Parkinson's in both there's a type of frontotemporal dementia called PSP, or progressive supranuclear palsy, and corticobasal and Lewy body, and those can have Parkinsonism. So also the biomarkers and PET scans and neuropsych profiles are quite different. So I think if you pay attention to the imaging, the clinical picture and the neuropsych profile, and sometimes even biomarkers, we should be able to distinguish between those things. But I don't blame any clinician. In the early stages, it's difficult, and it does evolve, and you have to be able to be flexible and change your mind when the diagnosis changes.
Okay. For the interest of time, we'll do one more question. Since anesthesia can be a problem for Lewy body dementia patients, how do you treat when needed to be prescribed for a procedure?
So there is this interesting observation that people who have general anesthesia are very sensitive, dementia patients are very sensitive to general anesthesia. And so they have a dramatic effect on the picture, the immediate picture. The anesthesia works because it dissolves in fat and goes into the brain. And when it does, like the barbiturates, and when they go into the brain and are dissolved in fat, it takes a long time to get out because it's dissolved there. And so people on the knife edge, when you tip, just a small tip is a massive tip for them. And so you see a dramatic change. Say they wake up from the anesthetic when they don't recognize the family and they're wild and they need to be, and on top of that they then get sedated for being wild. And so it's sort of a self-perpetuating thing. So anesthesia is riskier in people with dementia, that I could say. Often, or most often, they actually do recover if given enough time. So anesthesiologists who are excellent, they modify what they use. They use the difference, maybe a little bit less, or they, different ones that don't dissolve or live as long in the brain. And so they, as long as your anesthesia person is aware, and we still can go ahead and do that. We can do a lot under local anesthetic now. You can do hip replacement if you feel like it under spinal anesthesia. So there are lots of other alternatives. But if the operation is necessary, then there are good strategies with good anesthesiologists to mitigate the worry. The other thing that we always advise is that the spouse or care partner needs to stay with the person in the hospital if they can. Because if they orient them, they feel safer. Otherwise, they're in a strange place, don't know how they got here, and are confused, and then they just fight. So, tell the loved one that if they must get several of their loved ones to, have a list of and schedule to stay with the loved one in the hospital. That's often very helpful.
Thank you. And thank you so much to our presenters today as well. For the questions that we were not able to address, we will have them answered by our panelists, and then we will contact you with those answers. Right now, we will take a moment to just raffle off our baskets for those of you in the audience today as a token of our appreciation for attending with us in person. And to those of you on Zoom, thank you so much for joining us today for our event, and we hope to see familiar faces for next year's event as well. I'll go ahead and raffle it off. We have 2 gift gift baskets in addition to some free tickets to the Jacksonville Sharks game if you are a Sharks fan. It will be for our June 21st home game. And also, a certain amount of the proceeds for the tickets actually go towards our research center, just so you're aware. So the first winner we have 962002. There you go. And Anton's coming with your basket behind there. Alrighty, and then we've got the next ticket. This is for those 2 free tickets to the Sharks game, 962026. No? They must have left early. Snooze, you lose. Next one, 962003 for those tickets. Yes. And now we have one more basket. It would be 962010. We've got one over here. And then the last raffle for the remaining 2 free tickets, 962015. Oh. Thank you. And now we do have our fellowship and connection session, which is something we are hosting, kind of like a support group for our caregivers to one side and then those living with Lewy to one side. If you are interested in participating, we have our certified caregiver support group facilitators, Christine and Candace, who will be hosting organic conversations and perhaps answer any questions you may have in regards to whether you're a caregiver or someone living with Lewy. So if you are interested, please stick around and then we will disperse into 2 sides. But thank you so much for joining us today and we hope to see you next time.